Hey guys, thank you guys for watching. And today I wanted to take a little bit of time to talk about um, autism spectrum disorders, which falls under the classification of a class of disorders called pervasive developmental disorders. And we've all heard about them. We've all heard of autism. We've seen it, may even have a child or family member that has it. But a lot of us, we don't really understand what it is unless we know someone with it. So we're going to dive into it a little bit today and get sort of a brief introduction of autism spectrum disorders, and hopefully a little bit of a better understanding of them by the end of this. I apologize in advance. Some of my slides got out of order on here, so some of the stuff may seem a little bit out of order. And I'd already started recording this time I noticed it, but hopefully it'll still make sense. So basically, we're going to talk about autism spectrum disorders and what they are, and look at some of the other types of the disorders beyond autism. We'll also discuss some of the characteristics you see with autism spectrum disorders. And of course, we're briefly going to discuss diagnosis and some basic management strategies involved with them. So when autism was first identified, well, these kids were originally thought to actually be schizophrenic. And it was first identified in 1911 by a Swiss psychiatrist named Bleuler. And it was later termed autism by a fellow named Leo Kanner in 1943. And he came up with this based on observations of behaviors that he saw with these children, which we're going to talk about more here a little later. But Kanner's unfortunate choice of the word autism was meant to actually convey the unusual self-centered quality of these children. And although many of Kanner's observations have lasted, his speculations about certain aspects of the illness, like the normal IQ, lack of association with other medical conditions, poor parenting, education, a lot of that has actually been proven incorrect. Or inaccurate, maybe I should say. We'll also talk about Asperger's a little bit. Asperger's is also a form of autism spectrum disorder, and they are basically understood to be someone with higher functional capacity of autism versus just your classic autism. The title of Asperger's was actually created by a woman named Lorna Wing to separate it from general autism and to avoid referring to them as psychopaths, which we know today that they are not psychopaths. So she made a good choice there. And trying to go through the boring stuff quickly here. So the diagnostic criteria for autism spectrum are found in the Diagnosis and Statistical Manual of Mental Disorders, or the DSM-5. For those of you who are not psych people, that's basically the psychiatry Bible. And it gives us all the diagnostic criteria for how we diagnose mental disorders. So in DSM, these disorders are placed within the subclass of disorders. They're usually first diagnosed in infancy, childhood, adolescence, and they're known as pervasive developmental disorders. And there's a lot of other disorders that fall under this classification as well. But they are almost always diagnosed in infancy or at least in early childhood. If they are not, it's usually just somehow overlooked. And there are instances where that happens, and we'll talk about that also a little bit later here. So, quick overview here. Autistic disorder. The primary symptoms of autistic disorder are markedly abnormal or impaired development in social interaction and communication, and a markedly restricted repertoire of activity and interest. Diagnosis requires the presence of 6 or more of the 12 symptoms, with at least 2 being symptoms of impaired social interactions, at least 1 being a symptom of impaired communication, and 1 being a symptom of restricted repertoire of activities and interest. Students with autistic disorder typically have some degree of mental retardation as well. It's not uncommon to see it with it. It's not necessarily severe, but it's not unusual to see it. Given this fact, it's not surprising that it has been suggested that children with that have been assigned this diagnostic classification would also be eligible for special education criteria, which is it would almost be expected in modern day. And we'll talk about those diagnostic criteria, the 6 and the 12, a little later on. So this is where I kind of got stuff out of order a little bit. Asperger's. The primary symptoms of Asperger's disorders are severe and sustained impairment in social interaction. and the development of restricted, repetitive patterns of behaviors, interests, and activities, as it's quoted on the slide there. With the exception of not requiring symptoms of impaired communication, and in fact, Asperger's disorder criteria require no clinically significant general delay in language for the diagnosis. The diagnostic criteria for Asperger's and autistic disorders are essentially the same otherwise. But however, diagnosis requires that autistic disorder be ruled out before Asperger's is considered. And in addition, the cognitive functioning of individuals with Asperger's disorders is much more homogeneous. While individuals with classic autistic disorder are often cognitively impaired, the intellectual functioning of individuals with Asperger's is typically pretty much within normal limits. And given this fact, students with Asperger's will often require careful examination in the academic setting to determine if they actually need educational assistance. Where those with classic autism, they almost always need it. So, pervasive developmental disorder, not otherwise specified. That's just sort of a generic term. It's reserved for those who experience difficulty in at least one or two, I'm sorry, not one, two of the three autistic disorder symptom clusters, but they don't necessarily meet the criteria for a complete diagnosis of ASD. So a couple more here. Childhood disintegrative disorder. This one is a really rare condition. I have personally never seen it, but like autistic disorder, it involves impaired development of social interaction and communication and restricted, repetitive, and stereotyped patterns of behaviors, interest, and mannerisms as well. However, a distinct pattern of regression following at least 2 years of normal development is what distinguishes it from autistic disorder. And given the severe cognitive deficits typically associated with Rett's disorder, it is expected that I don't remember what the term is, in the academic setting in school, those teams that they'll certify these students for special education because they're pretty severely impaired usually. Examination of diagnostic criteria reveals that also Rett's disorder, which occurs only in females, you do not see this in males, is relatively distinct. In this disorder, a pattern of head growth deceleration is one of the things you'll notice. A loss of purposeful hand skills and the presence of like an awkward gait and trunk movement distinguish it from other pervasive developmental disorders. While social difficulties and characteristics of autistic and Asperger's disorders might be observed, they are not as pervasive and they tend to be more transient in Rett's. So, in addition, while the severe impairment of language development that can accompany autistic disorder is observed, in Rett's disorder, such as also accompanied by severe psychomotor retardation. And given the severe to profound cognitive deficits typically associated with Rett's disorder, it is expected that the academic screening teams will also certify these students typically to be eligible for assistance. They just can't function without some sort of assistance in school successfully. So, and let's see what else here. So moving on here. So what do we know about ASD or autism spectrum disorders? Well, researchers have been trying to find out the cause of autism since it was first identified by Kanner in 1943. Autism is a biological disorder with multiple etiologies. They have found no single cause nor a cure, no single biological markers. There is no evidence of parenting defects or emotionally induced autism. That's a common theory that's out there that you'll hear sometimes, and that's been disproven. Currently, the view is that some factors act through one or more mechanisms to produce a final common pathway of the central nervous system insult that results in the behavioral syndrome of autism. It almost always starts prior to the age of 3 and impacts every functional area of the brain. It is a pervasive developmental disorder and essentially impacts all areas of development, though some cases obviously can be more severe than others. So what else do we know about it? Current clinical research suggests that pervasive developmental disorder causes are likely multifaceted. Well, we just mentioned that, so we kind of know that already. But there has been some research to suggest that there is a genetic connection as well as environmental factors that are thought to contribute to the disorder. They have found abnormalities in the genome, such as in chromosome 15q and Q11 and through Q13. You don't need to know that. It's just some worthless information for you there. Is implicated based upon twin and family studies. Mechanisms underlying the expression of these abnormalities during brain development is also abnormal, resulting in structural and functional abnormalities in the brain and altered behavioral expression of autism. So, what is it about identical twin data that clearly indicates that a genetic defect is not a likely source of um, all autism spectrum disorder cases? Well, autism spectrum disorder runs in families, and identical twins, there's about a 60 to 90% concordance. So if autism spectrum disorder was purely genetic condition, we would expect 100% concordance among identical twins, and that isn't what we see. We see it's high, but it's not 100%, 60 to 90%. And with siblings, there's about a 3 to 6%. Um, However, with the exception of Rett syndrome, there is no conclusive evidence that autism spectrum disorder is actually identified with a specific genetic deficit. So as you can see, there's lots of areas out there they're looking at, and it's still not completely and fully understood. There are numerous other possible genes and chromosomal regions that have been identified that could play a role. Um, for those of you who may know or care anything about it, FXR1 is one of them. 20 to 60% of kids with this one are autistic. So other possible causes, to the extent we mentioned environment, to the extent the environment has a role in causing autism, it has been suggested that it does so by interacting with certain genes. In other words, a certain gene or gene combinations may generate a susceptibility to autism that is in turn triggered by certain environmental factors or factors. Environmental factors currently being considered and looked at include things like obstetric suboptimality, prenatal and postnatal factors as examples there. The lack of any specific factor as being the cause of autism has led to the study of summary measures of the pregnancy and delivery's optimality, maternal age, maternal disease, neonatal respiratory distress, things like that. Most studies that have considered obstetric suboptimality have actually found lower optimality among autism spectrum disorder individuals as compared to the normal controls. However, whether this is a cause or a consequence of autism spectrum disorder remains in question and suggests that these variables likely represent additive brain trauma to a vulnerable child rather than as a distinctive etiology for autism spectrum. Some other things, prenatal exposure to rubella, cytomegalovirus, herpes, HIV, thalidomide during the 20th and 24th weeks, medications like valproic acid, alcohol abuse, postnatal exposure to herpes encephalitis and other infections that can result in secondary hydrocephalus, exposure to and clinical illness from common viruses, things like chickenpox. There isn't really any data out there regarding the potential role of chemical exposures, but the measles, mumps, rubella vaccine, normercury, and thimerosal containing vaccines as well. So neurobiology, specifically brain size, has been identified in autism spectrum disorder individuals. Rapid and excessive increase in head circumference during the first year has been observed. MRI data actually suggest brain size discriminates ASD children from typically normally developing peers. More rapid growth, larger brain sizes is associated with more severe autism spectrum disorders. So what do we know about the brain chemistry? Well, it has also been suggested that the inhibition of GABA or gamma aminobutyric acid may contribute to the specific functional deficits in autism. They may have some examples with that would be the impaired ability to process sensory information and learning tasks. There was a hypothesis proposed, oh my gosh, I believe it was in the early 2000s, that suppressed GABAergic inhibition in autism results in excessive stimulation of glutamate specialized neurons and loss of sensory gating. So for those of you who aren't familiar with those, you know what GABA is. GABA is an inhibitory neurotransmitter. It's what your benzos actually target. Glutamate is your primary excitatory neurotransmitter. So that might make a little more sense for you there. And it is suggested that this hypothesis of impaired neurotransmission in autism is consistent with a broad range of findings from other neurochemical and neuroanatomic research that's out there. There's some research that actually provides a clear and concise review of diagnostic issues, prevalence and etiology of autism. They report that in terms of chemical pathology. And current biochemical evidence is at best speculative, weak, in some cases even contradictory. However, one of the more reliable findings appears to be elevated levels of serotonin in the blood of about 25% of individuals with autism. Although correlations with brain levels of serotonin, it remains unclear. There's no clear data there, basically, with this stuff. There's some theories, but nothing black and white. So, mirror neurons. Well, mirror neurons, this is probably something you have not heard of, and honestly, you probably never will again. But I included this here because mirror neurons are thought to be important for understanding the actions of others and learning new skills by the process of imitation. It is very basic. It's a very basic social system of the brain. And MRI studies have demonstrated decreased activity in parts of the inferior frontal gyrus, which is where these mirror neurons are located, thus potentially linking this to autism. And this is just a monkey see, monkey do. This is just an image giving you an example here of learning by imitation via mirror neurons. You can see the person there sticking out his tongue. The monkey is mimicking him and sticking out his tongue as well. And that's a process of those mirror neurons working there. So how prevalent is ASD? It's ubiquitous, occurs all over the world. It's not isolated to one particular culture or anything like that. CDC estimates about 1 in 100. That's data's from 2009. It may be a little different now, but it's probably not that far off. Delays in diagnosis result in an average of at least 1.5 years from the time parents first reported odd speech problems or other social deficits. And it occurs typically around age 3 before they actually end up finally getting diagnosed. Our increasing numbers, we are seeing increasing numbers slowly, tweaking up with autism spectrum disorders. And are these numbers real, or are they just the result of switching diagnoses? Well, the male to female ratio varies, but it's generally somewhere between 1 to 1 and up to 4 plus to 1. So it's definitely more common in males than females. Familial patterns have been well established. One study reports that each subsequent child born into a family with an autistic child has about an 8 to 9% chance of autism. Now that a little bit off from the data we just saw a couple minutes ago, when I think it said 3 to 6%. So depending on where you get your data from, there's some variation there. Twin studies show 60 to 85% concordant. That's pretty close to the other data, which was 60 to 90%, versus 10% concordance with fraternal twins. Population-based study of all 7 to 12-year-old children in a South Korean community This study used a high probability group from special education tools and a disability registry and a low probability general population sample from regular schools. Autism spectrum screening questionnaire for systematic multi-informant screening. Parents of children who screened positive were offered comprehensive assessments using standard diagnostic procedures. And prevalence with autism spectrum disorder was estimated to be around 2.6% with that. So I could go on that for a while, but it's kind of boring stuff. So we've talked about this already. Autism spectrum disorder is one of those pervasive developmental disorders impacting virtually every area of the brain. As we previously mentioned, one of the greatest hallmarks is inconsistent development. They do not typically develop with normally rates and patterns of development like most children, and they can have significant variations, such as the example on the slide here. He started speaking, then he stopped. So you can see inconsistencies with things like that. And that's a common example, actually. But just understand it's a developmental disorder and it is pervasive. So moving on here, while they do have developmental delays that are inconsistent, their symptoms are related to their chronological age, typically, and their mental age, and typically begin presenting with the first year of life in most cases, even though we just mentioned that they typically don't get diagnosed till they're at least around 3 years of age. But there are two types or classes of onset, if you will. The first one, often these children will lag in finding interest in playing developmentally normal games such as peekaboo by the age of 6 months, where normal developing children will begin to interact in that case. And the second is that they may appear to have normal development for the first 1 to 2 years of life, and then the symptoms will onset after that. The first one there is the more classic presentation, but you will see that second one there where you notice a little later onset sometimes. Some oddities you might see with these children are odd behaviors, repetitive behaviors, repetition, spinning. They get fixated on those patterns of repetition and organization. They can get very upset if things are organized in a manner in which they feel it should be. And someone come in and disrupts that. For instance, sometimes you'll notice they line all their cars up, their toy cars in a perfect line. Just an example there. They have things like rigid food preferences. They might struggle with interpreting and processing speech, using speech, difficulty understanding social cues such as eye contact, gestures, tones of voice. One thing to keep in mind is some of the symptoms can be developmentally normal. So just because they have one of these behaviors does not mean they have ASD. So be careful not to read into child's behaviors too much, as children just generally develop at different rates. So you don't want to slap a diagnosis on someone if they don't actually have it. You want to be sure of it. And sometimes that's why it takes so long for them to get the diagnosis, because oftentimes the clinicians just aren't 100% certain yet, and they don't want to give them the diagnosis just yet. So another thing that you may see with them is they often have, very commonly, they'll have high anxiety in certain situations, and they often have issues with coordination, just movement coordination and things like that. Very common in their development. As with many psychiatric and developmental disorders, autism is no different. You'll often see it comorbid with other disorders. Obsessive compulsive disorder is a very common comorbid disorder you see in those with autism spectrum disorder. Mental retardation is one that you see frequently. Some other things such as epilepsy, I cannot talk today, epilepsy, developmental stuff such as tuberous sclerosis and Turner's, those are actually congenital genetic disorders. ADHD, and of course, depression and anxiety always makes and manages to work its way in just about everything somehow. It's always in there somewhere. Social interaction. Social engagement or interaction is a very common characteristic um, of those with autism. You may notice early on if they have very little interest or possibly no interest at all in developing and establishing friendships. As they get older, you'll often see this improve as they do begin to attempt to have friends. But due to the other developmental characteristics, they often struggle with that social awareness, interpreting social cues, and how to interact with others. So as they get older, they want the friends more, but they struggle to develop that connection. Um, they will sometimes appear to have no interest or care about the needs or interest of others. Just understand that autism, uh, they're not being mean. They simply lack the capacity due to the pervasive developmental issues that you see with autism. Communication. Communication is another area of importance to note when looking at those with autism. They frequently will have delayed speech development, and when it does develop, it is often abnormal. You may notice things like immature grammatical structure or stereotyped styles of speech, such as repeated jingles, things like that. We just mentioned that they struggle with understanding social cues and social awareness. This can also be evident in their communication. Things like delayed comprehension and disturbance in social use of language or gestures can contribute to the misunderstanding of those with autism. Another characteristic to note is they often lack, or it is at least impaired compared to developmentally appropriate children, is imaginative play. It's often absent in those with autism. Those imaginary friends that you have, the autistic kids often don't have that. So stereotyped behaviors. This is a common one that most people associate with autism. We've pretty much discussed most of these on here. They'll have those ritualistic repertoire type behaviors and routines. If you've worked with or know someone with autism, disrupting their daily ritual can result in some pretty challenging behaviors from them. They tend to exhibit markedly restricted ranges of interest across the board. Not 100% of the time, but it's certainly not uncommon. And they can also develop fascination with movements and become highly attached to inanimate objects. This can come into play with those ritualistic type behaviors that they have, and kind of falls in line there. So now that we've talked about what a developmental disorder is, and we know what it is, but when we assess these kids, we need to assess all aspects of development to be sure we do not get too quick to diagnose someone with autism spectrum disorder. Starting with motor skills. Mentioned earlier, they often have impaired motor control and coordination. And in fact, about 80% of them actually have this impairment. Communication, we talked about that. They may exhibit issues processing and understanding speech. Social and emotional issues. They'll often have avoidance and isolation issues. They tend to not build those normal social relationships and seek out social interactions like most normal developing children do. Um, their cognitive and academic abilities, behavioral assessment, due to their rigidity with certain things, this can result in major can't talk again, major temper tantrums as a result. Also, as part of the behavioral assessment, you would look at their engagement with other children and yourself and their parents as the clinician. And of course, you always want to look at the family structure as a whole and do a family assessment also. So unless you work in a specialty clinic or this ends up being your forte population you work with, I usually send them for neuropsych evals to get a confirmative diagnosis, since there are people that are much better and more knowledgeable with this population than I know probably just enough to be dangerous with it. But gold standards of evaluations that they may use are things like the ADOS, the Autism Diagnostic Observation System, which is done directly with the child. And the other one is the ADI, the Autism Diagnostic Interview, which is done with the parent. And there are others out there, but I think these two are probably the more commonly used ones that I've seen. some of you may work in some other places. You may have seen some of the other stuff you just said. And as with all, psychiatric disorders, you always want to rule out other conditions, or in this case, be sure you identify possible comorbid conditions if you can. And you can do this in part by genetic testing. Um, genetic molecular screening can include like a Fragile X DNA probe, DNA for MECP2, which is a genetic mutation for Rett syndrome, which we talked about. DeGeorge's is another syndrome you'd want to look for. Prader-Willis, Angelman, fish chromosomal analysis would be another example. History and physical. You always want to do history and physical, hearing and visual screening. Speech and language evaluation. Obviously, that would be very, very important in this situation since it is a pervasive developmental disorder. You'd probably notice some issues there. You'd also want to have them evaluated by occupational and physical therapy. Why would you do that? Well, we just mentioned earlier that they have issues with coordination and movement. And OT and PT could certainly help validate that. Growth milestones, such as head circumference. Remember, they tend to often have larger heads, more rapid head growth when they're younger than a normally developing child does. Imaging, things like CTs, MRIs to rule out things or rule in disorders like leukodystrophy, tuberous sclerosis. Tuberous sclerosis is also a genetic disorder. EEGs, and of course, psychoeducational testing. You're probably not going to do that in a clinical setting. That'd probably be done in the home setting or by a specialist, but it's certainly one of those that you would want to work in. Metabolic screening from like a 24-hour urine to rule out some other things. Uric acid, calcium, phosphorus, magnesium. I'm trying to think. Homovanillic acid will be another one. Now, why would you do a homovanillic acid? Well, it is a screening for tumors that secrete catecholamines, such as things like neuroblastoma, pheochromocytomas, and even more importantly, things like neural crest tumors, things like that. So PCP chat, this is another screening checklist, and it's a common checklist for parents, and it is recommended to be completed at around 18 months of age. For those who fail on items 2, 3, and 4, they are flagged as increased risk and need greater evaluation or further evaluation. And on this, there's a lot of different styles of questions on here, but a lot of the questions on here are things like, looking for sustained eye contact, get the child's attention, then point out an interesting object in the room. Typically, the child should look at where the physician or the clinician points to. Ask the child to point out something in the room. For example, show me the light. The absence of pointing by 18 months is a cardinal sign of a pervasive developmental disorder. Show the child a doll and a cup and ask, can you give the baby some juice? An autistic child will have difficulty engaging in the pretend play. Ask the child to build a tower of 3 blocks. And really the purpose of this one is to assess them for their social interaction. Does the child enjoy being swung or bounced on your knee? Do they take interest in other children? This would be that social engagement, making friends. Does your child like climbing on things such as chairs? Do they play peekaboo or hide and seek? Do they have pretend or imaginary friends? We talked about all that stuff. Does your child ever use their index finger to point or ask for something? Do they play appropriately with small toys without just mouthing or fiddling and dropping them? That's just some of the stuff that's on there. I don't have it all in front of me, but it kind of aligns with the history there that you might see. The American Academy of Neurology has actually published a group of warning signs to be familiar with, and any child with the following 5 symptoms should be evaluated for autism. If they are not babbling by 12 months, that's a concern. No gesturing, pointing, or waving goodbye by 12 months. We actually just mentioned some of that on that chat screen we just talked about. No single words by 16 months. No two words spoken together spontaneously by 24 months. And when we say that, that means not echolalic. That means repeating the same words. And any loss of previously acquired language or social skills at any time. So basically, if they were previously doing something and then it went away, that's also a concern and a red flag for a pervasive developmental disorder. May not necessarily be autism, but could be some type of pervasive developmental disorder. What is the prognosis? Well, some children with autism show improvement in adolescence as they age, which is related to which has been related to better adult outcomes. Their activity level usually decreases. Their behavior becomes more manageable. Self-help skills can actually improve. Communication skills continue to develop and improve as well. Their IQ usually remains stable, and they typically tend to become more social. A large percentage, about 10 to 25% of children, will develop seizures as they age and get older with autism. Anxiety and depression are the most commonly co-occurring psychiatric disorders in adults with autism. Factors known to be related to the outcome. IQ by their age, by the age of 5 or 6 years old. Their communication skills by age 5. Early educational intervention is known to play a significant a role in how they progress. If you catch it, the earlier you catch it, the earlier the intervention is, the better they do in the long run. Factors that are not known to be related to the outcome are things like a family history of neuropsych disorders, adequacy of parenting. That is a common one, that theory that's out there, that people think that has to do with autism, and it has nothing to do with autism. And the family atmosphere doesn't really play a big role. Overall, I don't completely agree with that statement, because I think if you have a more supportive and engaged family for someone with autism, I think they probably are likely to do a little better. So we mentioned those DSM-5 domains, those 12 domains earlier, and they have to have 6 symptoms from those domains. They must have a total of 6 symptoms from the 3 domains. So they can basically, it can kind of be mixed and matched. They can have 2 from each, as an example, or they can have 4 in one domain and 1 from each of the other 2. That would also meet the diagnostic criteria. I'm not going to read through all these. These are easy enough to look up, and I think we've basically mentioned pretty much all of them already at this point. So I wanted to mention Asperger's here. We mentioned it early on there at the beginning, but I want to mention it again here because it's a topic that many people don't understand compared to autism. And basically, Asperger's is simply someone that is autistic, but they are high functioning, meaning they can often hold down jobs, things like that as they mature. And on here, when they say clinicians have been less reserved with the diagnosis, the reasoning for this is it's hard to get appropriate services and therapies needed started from the insurers if they don't have the diagnosis. So they tend to be, sometimes they're a little quicker to put it on there if they're pretty sure. But often the diagnoses are pretty apparent, and neuropsych testing results can often easily confirm the suspicion of the diagnosis. So Asperger's, according to the DSM, Asperger's looks like it is simply autism without communication problems, and that there's some truth to that. Yet perhaps the most conspicuous aspect of the presentation is that severe deficit in the social use of language, relative strengths in verbal ability, and weaknesses in nonverbal areas. Early speech development is not generally a concern, but significant problems in pragmatic or conversational skills can become evident with maturation. Limited inflection and abnormalities in rate and volume of speech are commonly observed. Speech is often tangential and can be circumstantial, resulting in somewhat of a one-sided conversation. Egocentric and unrelenting monologues. Every thought being verbalized and characterized by poorly organized sentences and paragraphs. Motor milestones may be somewhat delayed, though not as severe as classic autism. Motor clumsiness and awkwardness are often common, but they're usually pretty mild in comparison. Motor function often will improve with age. Um, less usual than autism to demonstrate motor mannerisms or preoccupations with parts of objects or non-functional elements of play materials. Individuals with autism spectrum are often interested in having friends and intimate relationships. They often approach others, but in eccentric ways. They've repeated experiences of failures that can lead to that clinical depression and anxiety. The relatively preserved language skills, which may manifest as a preoccupation with definitions, rules, facts, things like that, can be used to foster strategies for learning. So it can be used to their advantage in some cases, and cognitive methods for coping and to improve social skills. So Asperger's it's not as markedly identified oftentimes as your classic autism due to how mild it can be sometimes. Um, some will go into adulthood before they ever get diagnosed. It can present very differently at different ages and may go well into school age before it's diagnosed. And as I said, it's sometimes even into adulthood. The social disabilities related to it become more markedly obvious over time as they age. Mental retardation, you don't see it as much with Asperger's as you do with classic autism, though it's not unusual to see it comorbid. And it's frequently misdiagnosed as ADHD initially due to the characteristic social behaviors that can be seen with it. But these behaviors are markedly present enough to raise any flags of pervasive developmental disorder. I'm sorry, these behaviors, they're not markedly present enough. I didn't say that right. They'll often be overactive and they're inattentive. Remember, this is one of those characteristics of autism spectrum, not having concerns about others. But it's not enough that it raises red flags of a developmental disorder. They interpret it as attention deficit type behaviors instead. There has been question with the connection of obsessive compulsive disorder and Tourette's. Obsessive compulsive disorder is commonly seen with pervasive developmental disorders. Increased comorbid disorders such as depression and anxiety, as we previously discussed with autism. It's also seen in Asperger's. And this one's about 5 times more prevalent in males versus females. So pretty close to the same as classic autism. High functioning autism or Asperger's versus autism spectrum. Individuals with autism spectrum are more likely to exhibit higher verbal than performance IQs. In contrast, individuals with Asperger's are more likely to have higher performance IQ scores than verbal IQ scores. They found in DSM field trials areas of more predictive of autism spectrum versus Asperger's included deficits in fine and gross motor skills, visual motor integration, visual spatial perception, nonverbal concept formation, and visual memory. Autism spectrum individuals may have relatively fewer deficits than in theory of the mind. That is, an ability to have a theory of other people's subjectivity, if that makes sense there. So how do we manage autism spectrum and Asperger's? Well, I'll tell you, there are entire businesses built around working with this population of patients. And it starts in early childhood and it goes oftentimes into adulthood, depending on the severity. And even into adulthood, they still have to have some type of treatment, some type of therapy. One of the first things, obviously, family parenting, caretaker education, is helping them understand the disease and the disorder. Some of the behaviors with it can be a little bit challenging if you don't understand it. Cognitive and early academic interventions. We have found that earlier academic interventions have yielded better long-term results with the disorder. Speech and occupational therapy. Social skills training. They have a lot of issues with social interaction. So obviously that's an area you're going to want to work on. Applied behavioral analysis. There are people out there in a profession and they're called behavioral analysts. They often work with autism patients. Treat comorbid axis 1 disorder, stimulants, Strattera for ADHD symptoms. Sometimes they do have ADHD in addition to the autism. You want to treat the depression and anxiety, SSRIs, SNRIs. And sometimes we have to use antipsychotics. Not particularly a big fan of antipsychotics if we can avoid them, but depending on how much their how severe their aggression, agitation, belligerence, and stuff is, sometimes you have to, or they can get out of control. So you have to have something to kind of help keep them a little calmer. And here is some evidence-backed management that has some reasonable data with it. In October 2006, the FDA actually approved Risperdal or risperidone to treat irritability in children and adolescents that have autism. Risperdal was the first medication approved for use in treating behavior-related problems associated with autism in children. Now they also have aripiprazole approved, which is the brand is Abilify, I do believe. Classified under the general heading of irritability, these behaviors can include things like aggression, deliberate self-injury, temper tantrums. Haldol can also be used, but Risperdal is better. Compared to haloperidol, Risperdal led to a significantly greater reduction in aberrant behaviors, though risperidone can have some weight gain issues. And haloperidol, for those of you who are familiar with it, is one of the older antipsychotics, and it's got its own set of issues and side effects. So Risperdal is just, not only is it it has less side effects, it tends to just be a softer drug than Haldol. Haldol you could use in acute cases, like if you're working in the ER or something like that, inpatient, you're going to see Haldol used more in those environments. There was a review in 2006 of about 800 children treated with risperidone for disruptive behaviors. Found that the weight gain that you can get with it actually stabilized after they were on it for about 6 months. And the initial increases in prolactin came down after they were on it about 3 months. And for those of you who are not psych people, antipsychotics can actually cause increases in prolactin, which can cause gynecomastia in males and inappropriate lactating in females. So just something to be observant of. The most common adverse effect with Risperdal was somnolescence. Aripiprazole and olanzapine, which is Abilify and Zyprexa, were also shown to be useful. The problem with olanzapine goes back to the weight gain. It has some pretty rough weight gain with it. We already talked about applied behavioral analysis. It focuses on, for those of you who aren't familiar what it is, it focuses on teaching those small, measurable units of behavior in a very systematic kind of way, and they tend to do better with this type of treatment. Problematic target behaviors are usually chosen, antecedents are identified, and then corrective behaviors are taught. It's almost like a therapy for them. Typically, a question or command is given, a clue or hint is given as necessary. Correct response earns immediate reward. Incorrect responses are ignored or neutrally corrected. Something not on here, a low gluten diet was actually found to have shown improvements in those with autism spectrum. It's a little bit of an odd characteristic, but the evidence is out there. And obviously speech and language therapy and occupational therapy. So it's a very multifaceted approach to managing these guys, and oftentimes it can be lifelong, depending on severity. So. All right, that's all I have for you guys. Sorry it was kind of long-winded there. If you have any questions, just reach out.